All right, I'll start off with the objectives of our talk today. We want to identify the benefits and some of the challenges of iCentra implementation and review the training and support plan that's already underway, of course. We want to discuss how we can use our zero harm principles that we've all learned to have a safe and effective implementation as we face this significant change. We'll talk about local physician leaders in as much as this is really a physician and provider audience, and describe how you can help to contribute to improving the system. We have no relevant disclosures to make, and our objectives to address gaps in knowledge and the desired results are to address the key challenges to a successful EMR implementation and how to address them, particularly for areas of computerized provider order entry. And we'll talk about change management and skills for successful transition in any large transition. And we'll talk about the nuances of encounter-based ordering, which are new to all of us. So we'll talk about how to employ the zero harm principles to our benefit during EMR adoption, and again about the informatics organization, so you know what the leadership structure is going forward. So I'll have Joe start talking about a little background.
So it may seem self-evident to some of you, and so I'll make this brief. As you use our clinical information systems that we now refer to legacy systems, Help 1 and Help 2, there are shortcomings. But back in the 1970s, when Help 1 was first introduced at LDS Hospital, Intermountain was viewed as a leader in electronic medical record development. And this was expanded and deployed across Intermountain facilities through the 1980s and into the 1990s. As early as 1990, when we opened this building, Help 1 was in use here, but not in ways that many of you saw directly. It was in sort of the background. As this spread across Intermountain, we had the advantage of nurse charting, we had the advantage of a computerized medication record in the hospital, but it was separate for each encounter and separate for each facility. We didn't really have a longitudinal view of that inpatient care of patients. Later, we added Help 2, which was a web-based view into some of that same information, and it ultimately became the platform that Intermountain uses for ambulatory care, and many of you are using that. Again, we had a form of a longitudinal view, but it wasn't integrated with our inpatient view. And over time, pressures from programs like Meaningful Use and other regulatory programs put tremendous pressure on the developers to focus on meeting requirements of the government rather than enhancing the system. And these programs became a little bit long in the tooth. Further, although there were significant areas of expertise and advancement well beyond most of the commercial offerings at the time, Intermountain really had not approached physician-facing functions in these applications. Particularly Help 1 lacked any sort of direct physician order entry component or other physician-facing elements. So it became obvious that we needed to look for something that was a little bit more unified. So from a patient perspective, a single, truly integrated longitudinal view of the patient. This leads us to 4 things that really iCentra is for us. iCentra, in terms of scope, will replace all of the clinical information systems at Intermountain. Help 1, or Tandem as we call it, Help 2. It will also replace the inpatient patient accounting system. For those who are employed physicians and using Centricity Business Solutions, what used to be called IDX, what the university also formerly used, that will also be replaced. And we will have this system replacing all of those, as well as an enterprise-wide solution, an enterprise longitudinal view across all points of care for patients. But in addition, specific to us, starting with the initiation of the project in 2013, we have focused at Primary Children's on building pediatric-specific content for this entire enterprise system. And many of you have been involved with us as you have contributed to that content. But from the beginning of the project, we recognized a need for specialty content, specialty configuration that would be suitable for pediatric care. In addition, we envisioned and are underway in preparing for transitioning the university ambulatory providers from Help 2 to iCentra so that we continue to share an electronic health record for inpatient and outpatient care, not only across all of Intermountain, but for our pediatric subspecialty care. And so engaging with the university to address specific issues as Intermountain becomes the vendor of the ambulatory solution for the University of Utah, has been a key part of the project from the outset. So we identified a need to move away from these legacy systems to a vended solution to address the longitudinal record, to address physician-facing components like order entry, and to take the burden off trying to keep up with changes in the industry by ourselves and benefit from a larger organization doing that for all of us. But when you do that, you want to be sure that you don't take this lightly. There are academic methods for how we approach our implementation. And so we're going to approach that from a framework that has been published in the literature describing best practices for implementing an electronic health record system.
This is an article from 2014. So this came out after we had started preparing to implement iCentra in the North region, first at Logan and other hospitals in northern Utah, southern Idaho. And this is a paper by Chris Longhurst, an informaticist, that describes evidence-based methods for implementing an EMR. And it reviewed some of the literature, and many are familiar with articles like one from 2005. They reviewed actually some increased mortality in pediatric ICU after implementation of a Cerner medical record. But since then, in 2006 and in 2010, there were publications of unchanged and actually improved mortality in like ICUs, which led them to the conclusion in the paper that the hospitals in these studies used the same software vendor, suggesting that local implementation decisions are a critical factor in determining the safety performance of a computerized provider order entry system. That really is the big change we're talking about implementing in terms of the way it affects us as providers, prescribers, writers of orders, directors of care. It is the fact that we are putting these in ourselves is really the single largest change. And it calls out that we have as much attention to defining and redesigning our current care processes as we do to anything of technical build in the EMR. So we'll talk about why those things are so important on a framework of these evidence-based implementation methods of project planning, design and build, system testing, training, and optimization, just to help organize the discussion today. So first, let's just talk briefly about the iCentra project governance. I think it's important to mention that from the inception of the iCentra project in 2013, it has always been a project led by clinical providers with systems expertise. And these clinical providers, physician, nursing leaders, work with the information systems personnel, with IT, and with other groups to help take the workflows we know we need to do, the jobs to be done in delivering care to patients, and use the informatics and technical solutions to get them done, rather than say, here's your solutions, and entirely drive your workflow around the solutions. So it's really been a project governance designed to meet the needs of the clinical operations in our units, clinics, hospitals. Overall led by Vivek Reddy, our CHIO, our Associate CHIO, Diego Ise Ludlow, who's a pediatric endocrinologist, and our Chief Nurse Informatics Officer, Diane Rindlisbacher. Now, our primary children's region informatics leadership, Intermountain has regions. Primary children's is a region. Sure, we are a hospital, but inasmuch as we influence and deliver care to children across the Intermountain and beyond area, we are a region. Those participating in the informatics leadership include Judy Geiger, that introduced us here, Alison Larson, Joe Hales, and myself. And there's been project management that's changed throughout the project as it's evolved. Most recently, Jason Bartholomew, who will soon have a new role as the Regional Director for Continuous Improvement in the Central Region, have all helped us get ready for implementation. But you will not see the end of us. We are not going away, despite you may want us to. So I think it's really important for us to spend a few minutes talking about change management. This is a transition we're going through. A change can be thought of as a flip of a switch, But a transition is a process, and we all proceed through that process at different speeds and have different experiences as we go through it. And truly, as you go through a transition, it's not the change that we all will react to, it's the losses. If we had not had any previous experience at all with any healthcare delivery, taking on a new EMR would not be perceived as a loss because you don't have any previous experience you're coming from. But that's not true for any of us. And Steve Bigler from the South region, Utah Valley Hospital, I thought he just put this brilliantly. He said, in this transition to a new EMR, people have a lot of fond memories of the old girlfriend or boyfriend. And they may think that, this was my old girlfriend. But they forget that she had terrible acne, actually. Or they might think like, oh, this is my boyfriend, but he had terrible BO. And it's absolutely true. And it's fun to laugh and joke about this a little bit, but it is absolutely true and very, very notable on the effect of providers and non-physician staff that we have experiences and we have memories and we are very ingrained in what we do, and we do it well. We've done it a lot. And to transition to something new, people will have a little bit of a hard time letting go sometimes. It's like, gosh, I was so used to the muscle memory of doing it this way in the record before. And those are hard things to move on from as you don't have that muscle memory yet in the new system. There are defined losses that we will all experience as we go to a big transition that changes the way we do our care every day. People will feel, and talks are especially susceptible to this, a loss of perceived status. We may see ourselves or see another as being really efficient, as always having the right answer, and it's pretty threatening to find yourself automatically in a place where you're questioning some of the most fundamental things that you do and the ways you think. And people may have a loss of identity in that moment and feel like, well, my goodness, am I ever going to get back to the way I was able to operate before? And it's key that as we're helping each other and helping ourselves through this transition, that we are empathetic and listen and acknowledge these challenges that people will face. People will feel a loss of competence. It's very common. I had a physician at McKay-D Hospital a couple of years ago as I was supporting the go-live there in the ER, walk out of a room and just kind of brain dump to me for about 2 minutes about this woman I just saw with right upper quadrant pain and blah, blah, blah. And I mean, he's got to encounter that, 20 times a month, in the emergency department. And I was just sitting here thinking, why is he going on and on as if I was attending and he was presenting to me, And I realized it's because he's lost his clinical swagger. He has, for a minute, really forgot how to actually care for this patient. And because of the newness of the experience of, well, I don't know where to start. There's things we can do to help providers through that, create cues, tip sheets, reminders, certainly training. We feel a loss of sense of control. And it becomes this way because we're not sure how long it's going to take to schedule this procedure outpatient, or to, what do I do to actually forward this note to the referring provider? Or I just put in this order, how do I really know if it's being seen by the people that need to see it? And that confidence develops over time, but we can help define the workflow and help specify how long it may take for tasks to occur. And then many losses people experience aren't concrete, and they're just part of our attitudes, our assumptions. The way things are is very subjective from one person to another. Their experience and their perception is going to be very different. But again, it's not the change people react to, it's the losses they experience. And really what looks like resistance from someone where it feels to you, or if you yourself feel like you're putting up barriers like, I just don't know if I can do this, it may be that they're experiencing loss, fear, uncertainty, or just even exhaustion. It can be a challenging thing to go into a big change, and we need to pace ourselves for it. This is a marathon and not a sprint. So I want to talk about clinical swagger for a second, because again, this is very relevant to physicians. This is someone I think of who had swagger, right? Always seemed to have the right answer and just kind of always knew what to do. This is another person I can think of that had swagger. I definitely think that Gal Gadot showed swagger, but really, clinical swagger. It's a context-dependent confidence in the face of medical uncertainty. If you didn't have swagger, you'd get paralyzed all the time in making decisions in the face of uncertainty. We all face that. If things were certain, patients would walk in with a diagnosis printed on their forehead, right? So it's context-dependent confidence that you develop because you've done this thing many times before. So how do you get that swagger in iCentra, right? Well, it takes a little time. It takes practice beforehand, and we're here to talk about what things we can do to navigate through this process we will all go through, where we're starting out with kind of an uninformed optimism, right? I think we're excited at this hospital for an implementation of an EMR that is fully functional, more than almost any other hospital's been, because we've been begging for it for years. There's so many things we know that we could do better if we just had CPOE and we just had an EMR that didn't have some of the gaps that we experience now. And then you get into it and you're like, whoa, I don't know how to do this now, and it's day 2 or 3 or 4 of go live, and I'm really starting to feel a little pessimistic that this is ever going to get better, and I'm ever going to get home at 5 p.m. again, and I'm staying till 6 or 6:30, and why is this taking me so much longer? And everybody enters the valley of despair at some point and feels like this is never going to get better. And how do we lift up the depression point of that curve and get out of things as fast as possible and get our swagger back? Well, you're already doing it. So attending training classes, participating in mock go lives and coaching sessions. It's important to go slow to go fast. When we are implementing the EMR in areas where possible, the Department of Peds and surgical departments have been very supportive of our recommendations of turning down clinic volumes to about half of what the usual capacity would be to give you time to learn. It's really key as you go through a new encounter for the first time in iCentra, second, third time, to really give yourself a chance to explore, well, what if this, what if that, what if this patient were a little bit different? What if I actually had to plan this outpatient infusion, but I'm not going to? How would I do it? And going slow to go fast is really key. And then it's very encouraged to share your best practices among your group. Physician advocates that we'll talk about a little bit later can help facilitate that. But as we start to learn from our experience, to share that among colleagues, there's pretty much no better physician coaching that happens about 2, 3, 4 weeks into go live than docs talking to each other and saying, hey, this is how I've learned to do it. And we'll talk about what we can do to help avoid bad habits being spread. But this is all to the end of really helping us put the child first. In order for us to continue to deliver excellent care for children, we really need to be familiar enough with the system to have the confidence to deliver that care. And I just want to remind us all, we take care of patients, not computers. And that's still going to be true after iCentra goes live. You're not going to feel it's true for a minute. You're going to feel like, well, I can't do anything without the computer. And sure, I mean, you actually have to go through certain steps in a certain order to get a surgery arranged in an upcoming surgical procedure. Or you have to get a patient admitted, you really got to go through this step and the next to make sure that your med rec is in place and everything. But when a patient really gets sick and the stuff is hitting the fan, you abandon the computer. You do not need an order in the computer for the pharmacist or the nurse or yourself to drop a dose of epi. You do not need an order on the computer to do chest compressions on a patient. You do not need an order on a computer to call a code blue, and you do not need an order on a computer to call, pick up the phone, Vocera, the ICU, whatever. So just remember, treat the patient, not the computer. So if we have a successful transition, what's it going to look like? Well, we'll get our focus back on the patient and not always on the computer. You guys experience that when you go to the doctor, right? And it's just like, are they hearing anything I'm saying? And the eye contact is poor. Get our focus back on the patient, that we really maintain our good teamwork. Zero Harm has really taught us to listen to each other in teams, have psychological safety. We'll talk more about that in a minute. We'll have willingness to continue to learn and retrain as needed. And we got to be resilient. So give yourself, don't head into the go live exhausted if you can. And if you can, try to turn things down a little bit in your clinical life if possible, and otherwise to try to be refreshed going into it, realizing this is a marathon, not a sprint. And we hope to avoid lower morale, less engaged or reticent providers. Try to hope that we don't develop bad habits in the absence of having good coaching or staying on the best path to go through a clinical encounter, an emergency encounter, an admission, a transfer of care, and try to give yourself patience, try to have patience to learn the best ways to do things. And then a physician at McKay Hospital, when I was a surgeon, a general surgeon, I was talking to him and said, hey, what's the hardest thing been about iCentra implementation for you? And I thought his comment was just very, very wise. He said, you know, you don't really know what it is you do until you're forced to change it. And I think so much of what we do is, again, it's filled with clinical swagger, it's context dependent, we're used to doing it because we've done it a lot, but if you really dissect the process, well, when I put an order in for blood and wrote it on the sheet and handed it to the clerk, all this magic happened, and an hour later the blood's at the bedside, and I have no clue how that all happened. And I don't know what the full process is, the clerk doesn't, the blood bank doesn't, no independent one person knows what the full process is until we're forced to change it. So, all right, well then how have we, with that realization that really to understand our full workflows of how the hospital operates and how one thing leads to another, much of our work over the last 3 years has been about looking at workflows. Here's an example of where maybe this had been like the intention, right? You got a nice path, and you don't really want people getting stuck by the barrier, so you create a nice little area for them to move around. But in reality, the users are like, well, that's ridiculous. Why in the world would I ever go there? I'm just going to go the most direct path to where I want to go. And so even well-intentioned design can work out bad. So you want to focus on what is the job to be done. And if those building this would have realized, well, the job to be done is to get the patient safely to the crosswalk, it would have been obvious what to do, right? This, you're not expected to be able to see this. This is what we do. This is what us nerdy informaticists do. We map out workflows. We sit down with subject matter experts and we figure out what leads to what, to what, to what, and what are the different areas it interconnects. These are 9 feet long if you print them out on paper that's large enough to read. And this is what happens for patients before they come to get an infusion in the RTU and when they're actually there to get the infusion in the RTU. Why do I show this? It just shows that we have tried to focus a great deal on understanding what is it that we actually do. Then use the tools of iCentra and the electronic medical record to help us deliver that care, again, rather than the other way around. So the greatest challenge with iCentra, again, is computerized provider order entry. Otherwise, Help 2 does most of what iCentra will do. It lets you review results, lets you do documents, lets you send messages, but it's really entering orders. And a big difference with computerized provider order entry is that there's greater precision required when you're essentially, it's not seen this way by a provider, but you're essentially coding a program when you're putting in an order. You're saying the dose, the route, how frequently you want to do it, and you're saying something about what dose form is it? Is it the liquid with this concentration? Is it the pill? Whatever. And is this to be done now? Is it to be done tomorrow? How many repeated times is it to be done? And if you look at the orders that are written out on charts out on our units through the hospital, and you really go look at them and examine cases, every detail there that would always need to be there to be totally clear about how to give that, and many times no. And our nurses, our pharmacists, our clerks kind of fill in the gaps, right? Figure out the dots that are unconnected. If you try to do that in a computerized provider order entry system, and not put in one of the details needed, it will let you know because it doesn't know what to do with it. So they're much more explicit and literal. The benefit of that is that there's greater reliability and we can do more with that information. The risk is that it can be more workload to the provider. This is just a little visual example of the medication administration record in iCentra. This is it's like very boring appearing and like one of the older functionalities in Cerner that's been there for many, many years, since probably Cerner ever was used in hospitals and before 2000. But it's one of my favorite things because right now I am so frustrated all the time that I can't figure out, well, when did the last dose been given and when is the next dose due and when was that medication last given? You just go here and look, and it organizes all the meds by what class they're in. Coagulate. I want to be like, well, we want to do a surgical procedure on this patient, but is it safe? All right, well, have they had a recent anticoagulant or antiplatelet agent? Oh, I don't know. Ask the nurse to print something from Help 1. No one can tell me. Or maybe I'll flip through all the old pages, but the only ones that are there are the last 4 days, and the others have been chart thinned and thrown out, right? And we've had real safety errors that have happened because no one could really very well tell, even from a Tandem or Help One printout, what meds had been given. And you just go to the MAR-View, you look at coagulation modifiers, and you can see exactly what was given. Now, you always need to be cautious that what are you looking at? And this right here is telling you August 23rd through some other cut-off date that the screen wouldn't let me show. But it will show you what you're looking for, because the orders were put in precisely in the first place. So that's the value of having computerized provider order entry. I want to talk next, though, about something that is entirely new to all of us because we don't think this way, and that is the FIN. I'm not talking about this FIN, or that FIN, or him, or there, but the iCentra FIN is the financial identification number. It's an encounter, you know, the encounter number on like face sheets and stuff at primaries now. That's essentially the same thing. A FIN, a financial identifier number, is unique to the patient on this day in this venue of care. So it's very, very unique identifier, just like the encounter number is, but we will use it in ways we've never used the encounter number before, because it's relevant when you're really planning future care in a particular location. If I'm a surgeon seeing a patient in clinic, and I would like this patient to receive a certain surgical procedure, I have to get my clinic staff to request that FIN for an upcoming surgery so that I can put my orders in on that FIN. If I put my orders in on the clinic visit today, the patient shows up to the surgical procedure and there's no orders for them. Okay, it's very context and location dependent. So that's something that we've never thought about before, really. Now, I don't want to spook you about it. I just want you to be aware about it and realize that if you are treating a patient in clinic or inpatient and 2 weeks later you want them to have a CBC, you don't need to worry about the FIN. You just put that in as a future order. It's kind of floating out there in the ether of iCentra. And when they show up in the clinic to get it, the clinic or in the phlebotomy lab to get it, they can just pull that order down. But we're talking about power plans, real plans of care. If you're planning a surgical procedure, an admission, so forth. If you have a patient that's being transferred from Riverton to Primaries Children's Hospital, or from like an Instacare as a direct admit, or even home direct admit, you can't just go find any old FIN in iCentra and put your admission orders on that. You got to put it on the pre-admit FIN that the transfer center has arranged while the patient is on their way in. Otherwise, the patient gets here, they get admitted on that pre-admit FIN, it becomes an inpatient FIN, and there's no orders on it because you put it on some random FIN, wherever. Totally new concept. We're going to make mistakes on it, and that's okay. We have people there to help us through it, okay? But just totally new concept. It's not, definitely not germane to what we do now. Let's just talk briefly about design and build. So we've gone through a lot of stuff so far to talk about the project leadership overall and the project vision. We've talked about the change management. Now just talking about design and build. So this has been accomplished with an experienced team. Many of you have participated with it. Many of the people on it are internal to Intermountain with Cerner consultants. But again, the key point at the bottom one, informed by subject matter experts, but guided by workflow experts, and then using the solutions that Cerner can provide us to deliver the care. So we have been doing this design and build for 3 years. On top of all the rest of Intermountain has been implementing. And Joe, do you want to talk to that for a moment?
So just to set a little bit of context, Intermountain made its decision to implement iCentra in September of 2013. In October of 2013, teams arrived from Cerner and we began an assessment of Intermountain, which included at that time Primary Children's. In contrast to these other facilities that you see here as we've gone live through 2015 and as recently as last July, where teams would be engaged a few months before the implementation, we've had a team engaged with the enterprise development team as well as the Cerner resources from that time in October through to the present time. And as we have implemented in these various locations, learned things, refined the configuration, enhanced capabilities, addressed concerns, all of that has continued to feed the work that Eric was describing earlier of the enterprise resources and our local teams, augmented by many of you participating in that development. And so we have continued to perform ongoing assessments of the workflows that Eric described, and that has informed the specific configuration. But an important part that Alison will talk about later is not just the assessment and configuration, but we have unique workflows here that are not present anywhere else in Intermountain. And so an important part of this configuration, this design and build process, is to validate what we've done in terms of that configuration. And so since April, we have been conducting parallel testing where we've taken those unique workflows, taken those workflows that represent substantial change from the overall build, and been testing those to make sure that we have that configuration right. And now mock go live is another phase in that. It's very late in the game, but it's an effort to actually engage providers much more directly, closer to the time that they would actually use the system. So it is a form of training, but it also helps us validate the system as a form of testing. And we continue to make changes in the system as well as in the technical equipment deployment as a result of that, in an effort to help prepare for the go-live ultimately. So all of that is leading us to where we're headed in terms of testing, but we want to talk a little bit about zero harm.
Thank you, Joe. We all, I think, are pretty familiar with zero harm principles, and we want our gains in zero harm to help us be safe through the transition to iCentra. So I want to speak briefly about three main areas that can benefit us if we focus on them in the iCentra transition. So first, speaking up for safety. We need to make sure we create psychological safety, and hopefully we already have in our units and clinics and so forth. But proactively admit your fallibility, and you can go, it's okay to go in clinic and be like, hey guys, this is like my third day in clinic, and I see that, let's see, I haven't worked with this MA yet, and I haven't worked with this nurse. So let's make sure we're communicating well and talking about things we're not sure if you're going to see this order I put in or this task to do. And I've really learned well from Joyce. I got to call out Joyce on this, that Joyce does this so well. When someone speaks up to you and says, hey doc, can you put this order in again or something? You might want to bite their head off when you're stressed about putting orders in and you're really busy and it's iCentra Go Live, but responding well when others speak up to you and say, hey, you know what, I put that order in, maybe you're not seeing it, can you check with the super user to help you there? Often it is that the doc did it right, and sometimes it is that the doc thought they did it right, but they didn't. But if you bite someone's head off, they're not going to want to speak to you the next time, and that's a safety risk there. And remember Maya's rule that every primary children's team member has an absolute obligation to speak up for safety. And a good example of this is that at one of the emergency department go-lives, a physician was putting in orders, and he realized that there was something not quite right with one of the quick orders built. And instead of just like going through it and being like, well, I can modify that, I guess it just doesn't work for my situation, he spoke up and said, hey, you know what, there's maybe something we want to address here. He just provided the FIN number to the super user there, or the physician coach. They submitted a ticket and ended up benefiting the whole system to just that one little change, where it could have caused harm downstream if someone hadn't spoke up. We really want to practice situation awareness. This is why we're slowing down in clinics, so we have time to appreciate and internalize the change. Think about the job being done in the present and ask for help if you need, and review and assess the risks in a situation that's unfamiliar. We have a couple stories about that Alison will have you share in just a second, I think. And also, do not proceed in the face of uncertainty. We really want that we want people to realize that there's going to be lots of uncertainty, right? You're not going to know exactly how a particular order is going to be seen by the nurse. We're not talking about things like that. We're talking about when you encounter a new power plan you've never seen before. You're admitting a DKA patient new onset and you've not done that yet in iCentra. Really take a second to look through that. Be mindful and realize that you may not what the right course to do may not be entirely apparent in front of you. And you may need to go through this unfamiliar power plan with a little bit more detail and review things more carefully. Perhaps just before your story, Alison, I'd like to share and call out a great example from Miguel Canocal Riverton. He's been super helpful in helping us test a lot of the stuff for the hospitalist service, and that will be helpful to us in inpatient care here. One thing he did well is when he was admitting a patient with diabetes, this patient didn't have DKA. He was using an order set that had the ability to care for a DKA patient in it with some certain fluids. And he just kind of took a moment and he said, hey, well, let me explore this and see what it would be like if I was treating a patient with DKA. And he looked in and one of the DKA fluid orders was wrong. And they had the D5 and the D10 switched in terms of their fluid administration mils per hour rate is what they were supposed to be. And this had been reviewed many, many times before, and just an error that wasn't caught. And so it wasn't even applying to his particular situation, but he was having that awareness, presence of mind, and mindfulness in the moment to be able to raise that. And Miguel's done that time and again. Alison, you want to share that great story you have too?
Sure. So I have a couple of stories to relate, particularly about not proceeding in the face of uncertainty. To Eric's point, there is a lot of uncertainty. You'll all go through this a lot as you proceed through your day. There was a situation at the ER in IMED where there was a nurse who was very vociferously against the move to iCentra, particularly the fact that it would be changing their workflow and they would have to now start barcoding medications, which they don't do. And this person was going on and on, I just don't understand this, we've never had to do it, everything's been fine. So he's in the midst of his first day of go live and he scans the medication and it pops up an error box, an alert. And so he stops and starts over, tries it again, gets the same alert. And then grabbed the super user and determined that there was actually a problem with the medication and it was not the medication he was supposed to be giving. So then he was very much a convert and singing the praises of, oh my gosh, I love iCentra, this is great. So there are some wins, but this cuts kind of two ways. I think it's very easy to, in the face of uncertainty, to want to negate, well, this program's just not working. You know, something comes up and it's easy to dismiss, well, and there were a couple of stories also in the IMED Go Live where that people would get some sort of an alert and just decide that the computer wasn't working and circumvent it, which is something that is very much high risk. I had a personal experience recently. My father was in the ER and the physician came down and was trying to access his chart and was very frustrated that he couldn't find, he's like, I can't find him, he's not in room 25. And it had turned out, and he said, this computer program just doesn't work. And it had turned out that my dad was to be transferred to one of the inpatient units, and he had already been transferred to the inpatient unit by the nurse. So the program was actually functioning exactly as it was supposed to, and it's easy to leap to the assumption that the program's not working. So those are things that I caution you about as you will face a lot of uncertainty. Things won't feel comfortable. So make sure you use your physician coaches if you have any nagging feelings and don't proceed. So along the same vein, we need to make sure that people are communicating more, not less. This is one of those times where asking questions, running situations by one another will suit you well, as opposed to thinking maybe you've got it and just forging ahead could end up in a risky situation. So along the lines of making sure that we're attending to safety, we have done as a system and as a facility a lot of testing. So we're the benefit of 9 other facilities going live with us being the 10th. We get to benefit from a lot of the bumps in the road that they've learned from, and we've been able to we'll be able to avoid those because they've already figured out how to navigate those. One of the things, though, that's risky for us is that, as Eric indicated earlier, there are some pieces of our build that are different. We'll have ECMO, we have transplant, we have infusions that are much more complicated here, and our processes have typically been different. So we've been working through those to make sure that they're working well for the pediatric population. There's also, certainly, as you all know, medication differences with dosing, weight-based dosing. We have different surgical procedures. So we've been doing a lot of different build, and we have been testing that rigorously. There's what they call system testing, where the QA teams test it, then we put it through some of the other testing that was described, parallel testing, then mock go live, which is, as Joe mentioned, a little bit testing, a little bit training, so that we can make sure that those are working as intended. So also, we have developed individual order sets here that we have that will be specific to the pediatric population and some specific to primary children's. Those have been tested a great deal by the orders team on the systems level. We have medications that have been tested by our pharmacy informatics people. We have paired up very well with them. And then we do have, as I mentioned, the workflows specific to us that we have been working on with a lot of diligence to make sure that they're able to be navigated in a least risky process as we can. So now you are next.
Just a few things about training and go-live support. Now, you're already all in the midst of training, attending in classroom training. Mocks are especially relevant in the clinic. Still valuable for the physician's inpatient, but not as essential as they are in the clinic for the physicians. There will be a care team lists video that's going to be sent out probably about next week to the providers, APCs, definitely next week to the residents. And care team lists are what we're using in iCentra to replace the team lists in Chameleon that we all use and print out and look at. And at Go Live, just know that you won't be able to reach two directions and not hit two support people. Oftentimes, by about 2 weeks in, providers feel like, hey, I actually need a little bit more space here. I want to figure it out on my own a little bit more. If you have a problem, something doesn't make sense, you don't know if it was you, if you don't know if it was the program, we're not expecting you to figure out. Just tell the fin of that encounter, that patient, to that super user, non-physicians, physician coach, physicians, and they will submit it out. It goes through a process that filters through to the right group. Though I would be thrilled to receive every single one of these from you in email, you'll be much more the response will be much more effective and speedy if you use the system of just submitting a ticket and have the fin submitted through the system. I don't think sarcasm carries very well on the recording, so don't just send them all to me by email. It's not the best way to go about it. Write down the fin and have a ticket submitted. Then it can get addressed by the right people. So again, don't disappoint Nemo. Remember the fin. All right, so transition, sure, it'll be challenging. We'll get through it, though. We're already going through preparation. Initiation is really go live to the first about 8 weeks. So again, this is a marathon. Even at 8 weeks, you're not going to feel like you know everything about how iCentra works, and you're going to never encounter a new situation where you don't know exactly how to deal with it in the computer. And so there's a long-term period of adoption, too. And sometimes that can be the most difficult phase because people start to lose patience and feel like, when am I never going to find something new, you know? And it's just, you try to take yourself back to being an internship or residency, and I think you might remember feeling that way then as well. So you just kind of have, don't forget that you know how to care for the patient. You may just need to grab the person near you to find out, hey, how do I do this particular job? Focus on the job to be done. Briefly, so for small fixes, call in that ticket. My favorite's disappeared. This documentation template isn't working the way I expect it to. And we might be able to fix these fixes literally that hour or that day at Go Live. There's a lot of support right there. But some of those fixes may not occur immediately. Larger enhancements, wow, as it turns out, we sure built as best as we possibly could the infusion workflows for the R2 and Riverton Children's Unit, but there were these things we didn't anticipate. And in order to address those concerns, we've got some mitigation strategies in the meantime, but we really need some technical solutions from Kansas City, from Cerner Core. And in order to do that, that might take some real time to get to. And so some of those enhancements need to be prioritized with this Region Coordinating Council, Allison, myself, Judy Geiger, and we prioritize those asks up through the system, and they may not happen immediately. So I just want to share a few quotes from docs you may or may not know. Shelley Ring at Southridge Peds has said, you know, with the physician coaching and Go Live support, Intermountain has really done it right. She shared an experience of implementing an EMR that wasn't iCentra in her clinic, and she's like, there was some support there for the first day, and then they were gone. And that's not going to be the case. At least at elbow support in all areas for physicians and providers, turned down as needed for 3 to 4 weeks, and then in many cases 6, 8 weeks or longer. But support will be plentiful. Josh Romney, my role in the central region, who works at Memorial Clinic as an internal medicine physician, has said that while CPOE takes a bit more time, I have increased confidence that the correct order will happen at the right time. Mark Ott, a surgeon, has said it's not always intuitive what to call something when I'm trying to order it. How to find it, he means. It's a bit like having to learn another vocabulary, but this comes out for things that I do uncommonly. So you figure out the common things pretty fast, and then you may have a few other things to step around or logs to step over as you move through time. Adam Kraft, a hospitalist at IMC, has made some really pithy comments. I no longer need to search for a paper chart. I'm so excited about that. I don't know about you, but I'm so excited about that. Which means I can finish my documentation from home, by the way. You know, I'm really excited about that. At my ER shift ending at 3 a.m., I can be like, peace, and then go home and, you know, wake up at 8 or 9 and finish documentation there. None of this dictating and mumbling at 4 or 5 a.m. I don't need to visit medical records to finish my documentation. I can write my morning labs and other stuff while I'm sitting there doing my note and don't have to go step out somewhere and find a chart. And the PowerChart Touch app allows me to view results anywhere in the world, which is pretty cool too. So I just want to briefly celebrate the work that many of you have done. And first, I really need to call out and give some special recognition to Dave Sandweiss. Dave, could you just stand for a second? So Dave Sandweiss. Dave is the assistant provider adoption lead for all things medical. Dave, as you know, is a gem of a human being, but he also is very sensitive to the provider's needs. He has taken on so many special projects and tasks, and I could not do this job without David. Chad Wallace, I don't know if Chad is here, but I don't see him. But Chad Wallace is our assistant provider adoption lead for the surgical services, and Chad has been a fabulous advocate. He has really helped message to the different surgical providers and make sure that they feel in the loop of things, as sometimes they're at risk to not, because they are not part of the Department of Pediatrics and don't have that same unified organization that us medical specialists do. Chad has been wonderful. Jeff Shunk, Dave Scarta, Brad Post have all been fabulous. And I don't want to ignore here, though this is a physician group, all of these people on Allison and Joe's team, Mitch Perkins, Allison, Joe themselves, and informatics analysts that work under Allison, they're really the people who get the work done. We help define what work needs to be done, and they're really the ones that work themselves and with the systems teams to get it done. Already acknowledged Jason back there, and Karen, thank you for your leadership all throughout this. And Judy, you're really missing from this slide, and we could not move on these things without the organization and support of our administration. Just briefly, I cannot name all the people here in the next 7 or 8 slides, but I want to give you a sense of just how many people have been so intimately involved in the configuration of iCentra in so many specialties. Some specialties we've had a lot of involvement, and other specialties there's just been one person taking it on. In some cases that reflects the work to be done, and in some cases it reflects just how, well, I don't want to disparage anybody, but if it was talking about me, just how nerdy, you know, they might want to be and be involved. The chief residents have been great. They have been super involved, both our former and our current chief residents, and thank them for that, for all the resident planning we are having towards the resident training. Really every specialty has been involved and has had great involvement from the division chief on down, and I cannot express enough gratitude for that. Many of the advocates, as listed here in green, are actually division chiefs in those areas. Not all, but many, and it just shows how engaged even our clinical leadership is at the division chief academic level. The NICU has been great at helping call out things well in advance of primaries because they're live elsewhere on iCentra. I got to just pay special attention to Phil Barnett, because this guy, he will turn things around so fast and spend countless hours reviewing things. And so thanks to him and Dick of his support of Phil in oncology space. Again, pretty much every specialty has been involved and with great work. Renee's picture is missing here, but not because she is not important. I can't find a picture of her. And then just got to call out Julia Smith. Julia has been wonderful at working with the surgical program and pulling some things together recently for surgery. So tools for success. For us to be successful in this transition to iCentra, remember it's a marathon, not a sprint. Not a sprint. You might feel like you need a sprint sometimes. Use a physician coach to practice in the system and practice and have patience with yourself in this transition. Realize that you'll get there. Slow down. Go slow to go fast, especially when you're entering orders, and enter them on the right fin. If it's a patient in the hospital, you found him on the care team list, you found him in the ER, you found him on the location-based list, you're not needing to worry about the fin there. It's when you're planning future care, especially relevant. Remember our zero harm principles and to communicate more and not less. Don't assume that just because you put instructions in the computer, the nurse will actually see them. If you communicate with them about things today, continue to do so. And you can help improve the system, and you can coordinate that with your specialty's physician advocate. So we want to thank you for giving us the opportunity to share some of these things and take any questions, please.
Okay, we have a couple minutes for questions.
Hopefully this will prove to be very tangential, but given recent events in Florida, Texas, good friends I've had during Hurricane Sandy, earthquakes in California, there have been times where even the best, most thoughtfully implemented electronic health systems have just not been available. I assume the corporation is working on backups should, God forbid, a natural disaster render all of this moot for a while.
So we want to take a lot of questions, so I'll try to be quick, but there is a lot of thought that has gone into this. There are two types of emergency downtime solutions that are implemented with that. One of them is entirely local. It's a copy. It's a limited copy that allows us to pick up where we left off in the facility. One can imagine that in a catastrophic event like a hurricane, that might deteriorate over time and we revert to other processes. But Alison team can speak probably to the paper backup as well. Each department will have an emergency kit that includes paper in the event that we don't have access to the systems. The other thing is that this system is running in Kansas City, and so as long as we have our network connections, that could be questionable, but as long as we have those, we have access to the system and it's bunkered down far away from here.
I have a question. Oh, did you have? I didn't know if your hand. So if, let's say we're on the floor and a super user is helping another person that's illiterate with computers like I am, is there regarding to the fin, because I am understanding this and we're our team and our division is going to the classes and all that, but is there a phone number? Let's say the super user is helping a DKA or the nurse that's, a super user is helping someone else and you don't want to bother that person. If you really want a ticket resolved, is there a phone number or is there another person to contact so you don't disrupt the super user that's actually doing a job for someone else, to be polite?
That's a great question, Molly. There's not going to be a shortage of that help. I guarantee that. There's going to be people around, and any times in which there is a perceived shortage, we will redirect those resources where it's needed. I don't really believe there's like a particular number other than the help desk.
Well, we will be handing out business cards that have a number that you can call. We want everyone to be aware of that. They are ubiquitously deployed, but as Eric suggested, that's really, you should view that as your backup, because we're trying to put a person at your elbow, and there are a lot of them around.
Questions? No? Well, I don't think we can thank these three enough.
Can I make a quick comment? I just, as a piece of parting advice, I would caution you that at the beginning of the go live, there's a lot of adrenaline and people are going full throttle, but you'll get exhausted. You have to watch that, and I think then when you find yourself getting to that piece, that's when you really need to use your situational awareness, slow down, because you'll find that as you get in a week or two, it gets pretty tiring, so.
Looking forward to that. Thank you.
Thank you.